your lab coat when you see patients and when you are in UR. Just I think has been the series of hot topics in 2018, and they are all kind of interrelated because basically lung cancer screening brings us to perform more minimally invasive with trying to get more patients out of the hospital soon with the idea not to have them back sooner, and with a perfect quality in the nodal dissection, and of course the major topic of neoadjuvant immunotherapy. So what is the role of thoracic surgeon in setting a multidisciplinary collaboration? I think the lung cancer screening is one setting in which we can flourish and we can demonstrate our role within the context of a tumor board or lung cancer screening board. And the actual hot topic was the results of the Nelson trial presented in Toronto last year at the World Lung Cancer. We all know about this by now. More than 15,000 individuals randomized 1-to-1 with a detection rate of about 1.1%. 70% of the cancers were detected at early stage. They found 26% reduction in lung cancer deaths in 10 years. Even in men, but in women was even more significant. So this is something that we should know by memory. And what about the quality metrics about the nodal dissection? We'll come back to that. Whoever will come at the ESDS ISLC session on Tuesday will hear more about that. But this is a nice paper that was published on JAMA Oncology, which just shows, look at the survivor curves, how they splay, they separate. And if you do just an R0 resection, you have the left upper schematic over there. But if you add to the R0 resection at least on one station and 10 nodes altogether, including 3 and 2 stations, you see that the splay, the separation of the curves is much more significant. So you have more information, you have more prognostic value. An opportunity for the future is the idea of using immunotherapy. And the year ended in Toronto with the medical oncologist telling us, you're done operating on 3A. Well, this is not exactly few. That's because of the Pacific trial. And we all know what was it, basically the addition of the Malbab after chemo-rad for advanced stage lung cancer. But I really invite you to read Harvey Pass's feature expert opinion on the Journal of Thoracic Cardiovascular Surgery, in which he basically emphasized that the concept of unresectability is very variable in the medical trials, and it's clarifying. That's why we have to participate in those trials. That surgery does better than radiation in terms of local recurrence. In any randomized trial, the surgical arm had the best outcome. And there is a safety for surgery after immunotherapy. And actually, is the experience of Memorial that is condensed in these 3 papers that shows very clearly. Let me just talk briefly about the middle one. It was a joint effort with Johns Hopkins, showing that basically 20 patients who were subjected to 2 doses, correct me if I'm wrong, of nivolumab pre-op, with stages 1 to 3A, underwent operation, resection, and actually 2 of these 20 patients even had a pneumonectomy. There was no mortality, and the actual response rate of pathologic response rate was 45%, correct? Correct. So this is important, and that's what we have to keep in mind, because there was another very important paper presented in Toronto, where this group from Spain basically combined the 2 treatments, the chemotherapy and immunotherapy, to obtain a fantastic pathologic response with a very high rate of complete remission. Now, of course, we have to improve surgical care. This ERAS is a way. I know you're not going to read this, but just want to show you the degree of granularity that this group has used to try to understand whether we can have guidelines in a very tormented part of our practice, like postoperative care, where the individual bias predominates. So the last one I want to talk to you about is the reflections about our patient population. Brendan Stiles is somewhere here. I saw him in the audience. Published this paper in the European Journal of Cardiothoracic Surgery, showing that actually there is no difference between smokers and non-smokers in terms of survival after surgery. And you see now the incidence of the non-smoking patients rising in time, and you see here again the lack of difference. If you have any doubt, if you want to see even more, I will strongly suggest this paper published in the JTO in the early months of this year that really revise what happened in 2018. And again, I want to invite everybody to come to New York and see this, attend to this very important meeting. It was very successful last year. Thank you very much.